Yeah, that's great. Thank you. I never know whether I can answer that. The question that popped up, can West Streeting's policies ever work? I never know what. We're not civil servants, are we? I can literally say what I think, although I might run the risk of saying something career limiting.
No.
So, Rachel, I've managed to share my slides, have
Yeah,
I?
yeah, they're up.
Okay,
They're up.
that's excellent. Thank you. Well, thanks for inviting me in, and it's excellent to be back at a Midlands Analyst Network Huddle. I really like these things. I've pitched I mean, the talk I'm going to give is about the shift from hospital to community. I've given it the sort of vaguely quirky title of Are we engaged in the mission of trying to shift care, or in fact, are we swimming uphill? You can tell by the way I've set it up. I'm going to make the case it's very, very difficult what we're attempting to do, and in fact, it's probably a bit more like swimming uphill. But in the sort of introductory blurb for the session, I tried to pitch myself as a hopeful pessimist. So I think it's useful to say up front that this endeavour of trying to bring about a more community-centric health and social care system is something that I believe is the right thing to do. Um, and I think it's important to say that because I'm going to spend much of the talk giving you reasons why I think it's going to be extremely difficult to pull off. Anyway, so there we go. There's a couple of things I'd like you to bear in mind. I'm going to speak for I think about 20 minutes or so, maybe a touch more. Um, as I'm going through, there's a couple of things I'd like you to bear in mind. There's the questions that Rachel gave you, but there's these two things as well. First of all, is the role of analysts. So some of what I'm going to talk about is going to draw an analysis, but is going to point to sort of big secular trends that it would be very difficult for analysts to do anything about. But I'm going to, at the end of the presentation, come to a set of things that I think analysts can really help the system gain traction with. So I would like you to be thinking about the questions that you think analysts could really get stuck into that would help the system to make progress towards being less hospital centric. So please, as you're hearing this, please bear in mind the role of the analyst. The second thing I'd like you to bear in mind is I'm so full of cold and so full of lemsip. If I cut out or go off piste, I mean, partly it's a function of age, but partly it may be a function of medication and illness as well. So I'm inviting you to be sympathetic towards me as I meander around looking at my shoes and dribbling a little bit. So anyway, there you go. A couple of things I'd like to cut me a bit of slack on if you would. The structure of the presentation, I'm going to cover three things. First of all, I'll talk sort of briefly about what we think this thing might be, shifting care from hospital to community and the rationale for it, why it might matter. I'll then come on to be more pessimistic about things. I'll talk a bit about what history might tell us about the likelihood of success in doing this. I'm also going to point to a factor which I think is enormous and basically overlooked, which I think the Darzi review just didn't pay attention to, and which I think gives us particular cause for pessimism. And then finally, I'm going to look at this question, but I really actually would much more value your attention on this is to like where might analysis really help us? And I'm saying this partly because I'm not an analyst. So what I'm doing here is hopefully inviting the analyst community into saying where its attention might be valuable. So that's what I'll cover. Beginning then sort of first of all with a quick look at what this thing is. So what are we talking about when we're talking about moving from hospital to community? So here we are. Here's a hospital. Here's the community, and the the policy aim goes by the jargon of the left shift. So it's a very, very headline level. We're talking about the notion that there is too much activity going in our hospitals and that more could be done outside. At a very headline level, perhaps that makes sense. It's all then up for grabs as to what that means in detail, for what it means for particular service areas, for what it means for particular ways of organising activities, clinical or otherwise. So it really will all be in the detail as to what this thing means. It's also perhaps worth saying that we have achieved enormous shifts, particularly in mental health and learning disability, which have got some analogy with what we're attempting here, but also I think some strong disanalogy. But nonetheless, that at a very headline level is what it is. If we think about why it is, the 10-year plan gives you this, I think, slightly startling declaration as to why this matters. They say if the NHS does not feel like a single coordinated patient-oriented services, that's for a simple reason, it is not one. And then it goes on. It's hospital-centric, detached from communities, and organises its care into multiple fragmented silos. and then starts to deliver the rationale. So we need to break that. We need to shift to provide more continuous, accessible and integrated care. So there's some headline feeling for the rationale for this shift being articulated there in the 10-year plan. Other reasons you get, we're getting older. Here's an illustration from a tool that Paul Seamer, which I think he's presented this at a previous Huddle did. If you click through into the hyperlink, or if you look on the Strategy Unit website, you will find it. Here's the age structure, the population pyramid for England in 2000. Here it is in 2043. We just look like a very different, in age profile terms at least, like a very, very different country. The organisation of care, therefore, at least on the face of it, perhaps ought to be different. We can then cycle that through to think about what that means for the health status of the population. Here I'm going to show you a chart. This is from Chris Whitty's report. It's a really nice report about healthier ageing in 2023. On the up-down axis, I never know which one it is. This is the percentage of patients with multimorbidity. Across the bottom, it's age, and then there's some cut by socioeconomic deprivation. And of course, what you see is the older we get, on average, the sicker we get, and the poorer you are, on average, the earlier you are likely to get sicker. Although age appears to be a great leveler by the time if you get over 85. So we're getting older, we're getting sicker. The other thing, an interesting piece of work from this is the Health Foundation's Real Centre, projecting health demands up to 2040. This is terrifying work. It's really excellent stuff, but actually really quite terrifying. You can see on the chart some period of time spent without illness, some period of time spent with illness, and then some period of time spent with major illness on average across the life course. There's the picture for 2010, there's the picture for 2019, and their projection through to 2040 is that what we're doing in effect is elongating periods of illness. So people will be around for longer, and a greater proportion of that time is likely to be spent in ill health. So we're extending life, but mainly the ill bit. So we're getting older, sicker, and there's more sickness around because of the pattern of illness across the life course. And then there's a further rationale, which I think is not well articulated really in policy, which is some sense that we over-medicalise. In particular, or really, this is generally articulated in terms of the last year of life or end of life care. Here's a piece of work commissioned by Marie Curie from colleagues at the Health Economics Unit and Nuffield Trust. And this chart here shows the way that we distribute health expenditure in the last year of life. And you can see by the sort of the colour of the chart that in the main we're spending it on hospital care and very little in community-based services. And the conclusion we get from the report is that we spend about 5 times as much on supporting people in the final year of life as hospital inpatients as we do supporting them with primary care, community care and hospice care. So there's some argument there. So we've got an older population, a sicker population, we're extending periods of illness across life, and there's some articulation of a rationale which is about over-medicalising and probably committing too many resources towards the end of life, or some sense that we are, or maldistributing them. And then when we roll that forward and we look sort of slightly more carefully about the resource question, again, this from the 10-year plan, I'm going to return to this quote, but they say evidence is unequivocal that more care in the community is cheaper and more effective than defaulting to all care in hospitals. Now, that's not the clearest sentence on God's earth. It's not absolutely transparent what might be meant by that, but you can nonetheless see a very clear sentiment that it's likely to be a better use of resources if we shift care into the community rather than providing oodles of care in hospitals. So there's my sort of descriptive take on it. There's my take on what we mean when we're talking about shifting care from hospital to community and why it might matter. I want to move on now to think about lessons we might draw from history. And, here I might come to addressing the question that was put in the chat about will West Streeting's policies work. I'm going to say what history might tell us about the likelihood of success. And I'm going to point to something that I think Darcy overlooked in his review. I am going to sound pessimistic, so here I am sounding defensive about sounding pessimistic. There's a really nice book. Rachel was mentioning reading more books earlier, wasn't she? Here's a nice one by Ben Flyberg. I think he's a professor of mega projects or something. It's quite interesting. guy. His book, How Big Things Get Done, and his basic question is, if you're looking at the likelihood of success for any given endeavour, you shouldn't start by examining that thing and ask how likely or not it will be to succeed given its characteristics. You should look at the general rates of success for that class of activity. So they would say you should look at, on average, how likely does the kind of thing that we're about to do, how likely is it to achieve, and why would we be different from that base rate for success? So that's what I'm doing here. I'm just looking at the base rate for success and trying to shift care. I'll do it through the eyes of Darzi and his independent investigation into to the NHS. And when he looks at this shift of care, he says the following: since at least 2006, and arguably for much longer, successive governments have promised to shift care away from hospitals and into the community. So he's saying this is not a new aim. In practice, however, he says the reverse has happened. And he gives us this nice pithy phrase. He says the left shift from hospital to community could in fact be characterised as a right drift. So I'm just going to spend some time exploring that claim from several different angles. First of all, the policy angle. He says 2006. I think it goes back way further than that. I think, I mean, the sort of usual starting time for this policy aim is the middle 1970s. So for every day that I've been alive, the official aim in health policy has been to shift care from hospital to community. There's a few documents on the slide there that many of you will recognise. It's also worth saying it's not just the UK that's in this game. Basically, the developed world minus the US appears to be undertaking this endeavour. So I think Darzi's right about the policy case. He perhaps understates it, if anything. The money case. This is a piece of work by Sally Gainsbury and colleagues at Nuffield Trust, just looking at where the money goes. The top line, this is expenditure on acute care in NHS trusts running from 2016-17 through to 2022-23. You can see, not by a whole lot, but it does tick up. And then here is money going to community healthcare by NHS trusts. So again, the picture Darzi is presenting, in fact, we've got a right drift rather than a left shift. Seems right to me if you look at it through the money angle. Rachel, you said you wanted to know everything there is to know about my life. Well, here is my mum. She was a district nurse. If we look at what's happened to her profession over time, this again is a chart from the Nuffield Trust. This is Billy Palmer. I've blanked out the chart of the name of the chart because it gives everything away. But here's what's happened to my mum's profession. Here's what happens to district nursing over the time period. It basically halves. Capacity in district nursing basically halves over that period. And the chart title, which gives everything away, is the lamentable decline of district nurses in the NHS in England. And I don't think Billy Palmer is saying there's a causal relationship here between my mum retiring and this shocking decline. Again, Darzi looks right to me when we think about it from the workforce angle. Here's another angle. Here is a piece of analysis by Stephen Wyatt, the strategy unit and colleagues looking at non-elective admissions, starting in 2011-12, running through to just before the pandemic. We're going to show you here activity, first of all, that we think could not be mitigated. In effect, a secular trend, nothing you could do about it. And we're going to contrast that with activity that we think could be mitigated, either by preventing these admissions or by substituting for them, providing community-based alternatives. And what you see is that the activity that we don't think could be mitigated ticks up, but not by a whole lot, whereas the activity in terms of non-elective admissions that we think could be mitigated by prevention or substitution, in fact, ticks up over that period. And, again, who knows about the causal relationships, but that does coincide with the eroding of capability in community services, primary care, and certainly in the public health grant. So I think Darzi's right on all of this. I think there has been a right drift. The point where I would depart from him slightly is where he starts to diagnose it, where he starts to say, well, what has been causing this? When he looks at the causes of the right drift in the review, Darzi says he points the finger at financial flows and contractual incentives, payment by results in hospitals, but block contracts in other parts of the system, and the incentives that gives you. I think that's right. He also looks at constitutional standards, how they apply unevenly across the system, and more to hospital-based care than to out-of-hospital care. And again, I would suggest that's probably right. He looks at the consequent way in which data and performance measures are concentrated in hospital-based care and not outside. And again, I would say that's right. Um, there's a few lovely bits in the review where you can, I mean, like it's empirically good stuff and it's full of data and full of evidence, but you just see this sort of political pot shot come through occasionally. And there's so many little jabs at Andrew Lansley and his reforms. He clearly hates the guy. And one of those little jabs is that Darcy says that there is a right drift, there's more resources going towards hospitals, whilst during a period of large-scale reorganisation of commissioning structures. I doubt we're so empirically minded that we're deliberately running that test, but we're definitely running that test at the moment. It'll be interesting to see. Anyway, so all of those things I either agree with or I think are funny. But I think there's something else. I think there's something really big that Darcy misses that is a huge and ignored factor when it comes to the right drift. And it's going to make the shift of care from hospital to community extremely difficult. I'm going to illustrate that by pointing to a piece of analysis that the Strategy Unit did for the Health Foundation when they launched their Real Centre. I'm going to show you changes in activity, elective procedures, community services and consultations in general practice. They're over different time periods, but we've got a decade, I think, or so in there, a little bit under 2 decades. And I'm going to show you this. First of all, I'm going to show you the observed growth. So what do we actually see in these changes of activity? Well, first of all, we can see that community services grow somewhat over that period, and we can also see some activity in general practice growing somewhat over that period. You can tell by the way I'm building up to it, the elective procedures one is going to be different, and there you go, that's how different it is. So, again, this is just the general story of the right drift. So far so interesting, but if we look at what is driving that growth, I think that's where we get to the meat of this. First of all, if we look at demographics and then we look at other factors, you can see when you look at the growth in community services and the growth in general practice, the growth you see is basically observed explained by demography. So getting, older, sicker, more people, those kinds of things, and services expanding to cope with that. Whereas when it comes to elective procedures, there is some expansion due to demographic pressures, but very, very largely the growth is explained by other factors. And when you look more closely at that, what you see is that, in a sense, that is a synonym for innovation. That is the growth in diagnostic and treatment possibilities, changes in clinical practice subsequently. And so what I think you're generally looking at there is the effect of innovation in resource allocation. So the effect of innovation pulling resources towards hospital-based care. Just very briefly, there's another piece of work, again by Steve Wyatt, which is very recently came out. This was published in December. Here we're going to be looking at 5 points of delivery: outpatients, non-elective admissions, elective, ED attendance and maternity. First of all, I'm going to show you total growth, and then I'm going to show you what that growth is explained by. So you might have a little guess yourself, which one of these is growing the most and why. In terms of total growth, well, you can just see I've ordered the tables. So the one with the most growth is at the top. I mean, outpatient attendance is the one that grows by far the most, then followed by non-elective admissions. But again, the interesting part of the story, I think, is what is behind that. And you can see it's the growth attributable to non-demographic change, innovation, changes in clinical practice, those kinds of things, overwhelms all the demographic factors, on average, overwhelms the demographic factors. So I think what we're looking at here is a really significant oversight in terms of our diagnosis of the right drift. And I think we've missed the effects of innovation. We can roll that problem forward then into current policy and to try and address that question of will the current set of policies work? So we've had the diagnosis, we've had the prescription in terms of the 10-year plan. The 10-year plan is long, isn't it? And there's got a lot of things in it. But I've heard it summarised by an NHS leader I really like. She said there's 2 things really in the 10-year plan. The first is neighbourhoods, which I think is you could see as the vehicle for shifting care from hospital to community, and the second is tech. And I've tried to illustrate that on the slide. My cheap shot in relation to this picture is that's not a community centre you can see. I suspect that's the inside of a large hospital. So it looks to me like there's a strong tension within the 10-year plan, and history suggests which side that tension is settled. History suggests that we will settle it in favour of ever greater medical advance and ever greater activity in hospitals. And I think there's a further tension. There's a tension within health policy, and then I think there's a tension between health policy and industrial policy, where, for a set of reasons we might all be very sympathetic with, the life sciences sector is, it's booming, it's growing, it's high research intensity, it's high value added jobs, is certainly being encouraged by industrial policy. Quite how health policy manages its products, I don't know, but if you're attempting to shift care into community settings, you would need to do something deliberate. You can't expect general trends to just play through. So that's my sense of how history plays. The final part of the presentation, I just want to look briefly at where analytical attention might be needed. And again, I'm really keen to hear from you about where you think analysts could help in helping make this shift to more community-based care. One of my observations, if we look across the decades-long policy efforts to shift care, is that we've inexplicably and woefully, I think, missed opportunities to evaluate properly and to accumulate knowledge. I think you can sort of see why some of this might be. We've got a policy aim of shifting care from hospital to community, but if you look at the way research infrastructure is geared, it is geared very, very largely around hospital-based care, such that I think what you have in the research cultures in hospitals is you've got the huge and in many ways beautiful edifice of evidence-based medicine, looking at effectiveness in QALYs. We have cost effectiveness research, we have research intensive clinical work. It's very prestigious and there's lots of money in it. And again, to be slightly crude about it, the out of hospital research activity too often contents itself with good practice case studies. When it thinks about effects, it too often thinks about savings to hospitals. The research infrastructure and the resources around are also pretty poor. So I think we end up with this situation where we just haven't spent time really accumulating knowledge about what works in shifting care. And I'm going to point to a couple of key gaps, but again, just want to invite your reflections at the end as to other gaps that you might see. The key gaps I want to point to, I'm going to point to by first of all outlining a sort of headline theory. Now, again, this is perhaps a little bit crude, but for the sake of illustration, I think it's not too far wrong to say that the basic theory that animates this shift of care is something like, if we provide proactive services in primary and community settings, this will prevent demand for hospital services and that it would be cheaper too. So I think that's probably not an unfair characterization of the basic theory. I'm just going to look at that from two different angles analytically. First of all, this question of proactive services in primary care. If you haven't seen this paper by Jess Morley on risk stratification tools, you really, really should look at it. It's a stellar paper. Morley and colleagues look at the way that risk stratification has been used in primary care to trawl primary care data, to spot people at potential risk of unplanned hospital care, and to proactively target them and therefore prevent that unplanned care. And they look at what's actually happened when these tools have been used, and they conclude the following: that the majority of real world studies report no change or indeed significant increases in healthcare utilisation. So as far as they can tell, the use of these tools either doesn't work or backfires. They then say there's an urgent need to independently appraise these tools that are already widely deployed in primary care. So we've got something that's already been, depends how you think about it, basically mandated, which appears to be backfiring. So it looks like we've just not done the analytical work to figure out whether these tools are likely to work in practice or not before mandating their rollout. And then the second part of so that's the first part of the theory: if we provide proactive care, it can prevent demand. Well, there's an instance where it appears to be causing demand. The second part of the theory: it will be cheaper too. And I just want to return to the claim in the 10-year plan that evidence is unequivocal, that more care in the community is cheaper and more effective. I mean, I don't know whenever evidence would be unequivocal. By its nature, it seems to me that evidence would always be equivocal. Nonetheless, let's just examine that slightly more closely. here's work that we have been drawing upon by Monitor from 2015, when we've been looking at the likely service economics around community-based care. And here's a quick summary of what Monitor conclude. They say, although community-based schemes may be cost-effective from a total cost perspective in the long run, shorter-term challenges prevent many of these schemes from delivering savings within the 5-year time period they looked at. There's a further sting in this tale. In addition, they yield actual cost savings if acute hospital capacity is closed, which they say, this is sort of civil servant speak, isn't it? Which is unlikely. And given that the UK has a relatively low bed base compared to most Western nations, I think unlikely is probably under-egging it somewhat. So here we just return to this theory as with our analytical glasses on. If we provide proactive care, in primary and community settings, this will prevent demand for hospital service and it will be cheaper too. Well, maybe, but there's a set of propositions in there that we should be trying to answer empirically. And so I think I just want to close by sort of saying, in some respects, how bizarrely little we know about what has been a standing aim in health policy for many, many decades. But also what an amazing opportunity, what a role that opens out for analysts of many different stripes. So I'd just be very interested in, whether you agree or not with that proposition that analysts have got this amazing potential role to play. And in particular, I'm really interested in topics and questions that you think analysts could focus their efforts on and apply themselves to. So that's that. That was my talk, Rachel. I hope that's been okay. I hope Lemsip didn't overpower me too much.
No, that was wonderful, Fraser. Thanks very much. We've got lots of comments and questions on Slido, which I'll share my screen in a second. So I haven't given anybody time to answer your actual questions, but I think they'll be pondering them. They're pondering them because it does feel yeah, it's not new. This as you've explained from the very beginning, but it does feel like it's a big opportunity for analysts to be sort of more central to this being a success this time. And some people, I've heard people say this is it. It does feel like we're giving it a big push with the neighbourhood programme and so on. And some people will disagree with that and say it might be more of the same, but we're allowed to sort of be optimistic about these things. I am terribly optimistic quite a lot of the time. Let's you've got a nice amount of time to look at the questions that people have posed, and we know that one of them mentions West Streeting, so you might have to revisit that one. But let's just see. Oh, he says no, and you can say move on. This is your show. Let me just share the slide with the comments on it. And I'll try and do them in order, but I'll try. But also I think for the questions that you've just asked, there'll be the most recent responses. So I might flick through. I apologize in advance if I appear to be flicking through the responses. So we've got one or two questions that I think would be useful to, and I think you'd enjoy answering. So we'll move on. I know now I've made you poorly, haven't I? I've made you poorly. Before I I'll look at one or two in Slido, then I'll come to anybody in the room if they've got their hands up as well. We've talked about WES, and so there is a question here. You may or may not know the answer to this, which is does NHS data benefit from ontological approach to mapping data sets?
Someone's going to have to tell me what they mean by that.
That won't. Well, I actually I may
ontology,
have to.
the way things are. I don't know. Does that mean does the data sets that we collect, does that match the way things actually are, the way services are provided?
I would have to.
If that is the question, I would say yes.
Yeah, we have a happy new year, and I would reiterate the very happy new year to everybody who is here. So looking at this bottom one here, I'll just do two more in here, then we'll come to the room. So how does an ICB manage to reduce such a reduced workforce? So this is obviously the current climate to deliver on the medium-term plan, let alone the long-term plan. And I suspect we don't know the answer to that, but it's a fair question.
Well, I suspect. Well, I mean, we don't know. We've done a bit of work Recently for a local ICB where the sort of question was something like, what is this thing called strategic commissioning? How might it work? Sort of how would we have to focus our efforts if we were going to be successful at that? And this is pointed to in the ICB blueprint as well, isn't it? But one of the and here is me just, I'm just playing to the crowd now, aren't I? One of the major things is the better use of analysis in strategic decision making. That must put challenges into analysis, so we must get better at providing strategic analytical inputs. And then the second is that the basic task of being a strategic commissioner it seems to me, is one of resource allocation. And so we would need to be thinking more like economists than accountants, and we would need to be thinking about how the distribution of resource over place and time can be done to achieve greater health gain for the population. And if we did that, my sense of the evidence is that we would be shifting resources out of hospital and into more primary and community based. So, and probably social care as well. Anyway.
Yeah, absolutely. Yeah, and I think there's obviously people are going through challenges at the moment with their own sort of organisations and the reductions in staff and everything as well. So we do recognise that, of course. So the other question here, moving on, I think the person in the room put their hand down. Is the shift to community a person-centred, care-driven effort, or cost-driven? Do you think?
I don't want to just do that ridiculous thing of just rejecting the premise. I mean, like, it could be both. And I think if we looked at care in the last year of life, we might conclude that we could both provide better person-centered care and help people to die better deaths, whilst reducing expenditure in hospital-based services. And we might also achieve further benefits of sort of reducing the moral harm to clinicians, who I think very often we put probably intolerable strain upon, in some senses, with our demands as well. So I suspect there are areas of care where we do spend really quite a lot of money, where there would be opportunities to both provide more person-centered care and to make better use of resources. The next question.
Yeah, so I enjoyed your presentation at AFA conference. Does this make me a groupie? I mean, unequivocally, yes. I would say to that person,
it makes you diagnosable. You're in a diagnosable minority of one. I think we should move on.
Fraser, there's another one. I will. I would, no, but just to pause on that one though. We did have some really good feedback from the presentation, which I think was a workshop that you did at AFA, and I think it was on logic models, was it not?
True. Yeah.
So it did feel like it was something, not next time. You'll be fed up with us, but I think maybe a couple of months if you could, because I think it's a really useful technique for people to be exposed to and learn about if they don't already know. Thank you for committing to coming back, Fraser. That's so wonderful of you. Yes, we will share the presentation. Now I'm going to flick now to the question in the chat, and then what I'm going to do, I'm going to go to the top of the questions on Slido, because some of them will be responding to your the questions that you posed in your presentation. So the question in the chat is, how do we avoid the trap of retrospective analysis to fit decisions made? That's from Dave.
Yeah, I don't know. I just need a bit more context on that, I think. Sorry.
Well, I suppose that's I suppose what that's saying is decisions have been made, and here we go. I've found some analysis to suit that. Difficult to avoid, but we try to do it. What we're going to say, we try to do it. Everyone will always do that.
Leave the room, stop answering emails. I don't know.
Yeah, we try to do it properly, don't we? I have another. I do have a hand raised. So, Jonathan, do you have a question or a comment? Jonathan Lloyd, you might be muted.
Yeah, just really a quick question, going back to the very beginning of your presentation. So you talked about demographics, but also what was really startling for me was that bit where, following on from that, was where you've done the years in good health. So it's like the first bit of years in good health was 44, then with some health issues, and then with some severe health issues. Now, this might be a slightly different take. Would it not necessarily be part of this process, maybe be even more cost effective, to concentrate on those things that would expand those first two parts of a person's life, i.e. years in good health and years with limited? Because again, it goes with your model. The further put somebody down that scale, there's probably more interventions, more interactions with the health service, and more cost associated with it. And like one of the key things that keeps coming up, or as things, is around obesity and diabetes, and that's kind of an impending explosion that's going to hit the NHS service and cost a small fortune. So thinking around that, is the kind of part of this, should there also necessarily be a bigger investment in like public health around reducing sugar? I know there's bits, but it always seems to be the bit that gets squeezed a lot because the impact's really, really, really long term.
Yeah, Jonathan, that's an excellent question. I've just popped a blog in the chat, which goes into it in hopefully more coherent ways than my LEMSIP's about to allow me to do. But at the heart of what I think you're describing is this assumption about whether morbidity would be compressed or expanded across the life course, whether in effect the 70-year-old of today is fitter and healthier than the 70-year-old of 20 years ago, and what that would be like, in 20 years' time, what the 70-year-old would be like. And when this hypothesis, to my knowledge, when this hypothesis first started kicking around, the general sense was that we would just get progressively fitter and better, so that the 70-year-old of the future would be fitter and stronger than the 70-year-old of today. My knowledge of the latest empirical evidence is that, in fact, the reverse is true, and that the baby boomers are less fit and healthy than the previous generation. And as you say, there are things in the works that would make you think that unhappy trend is likely to continue, and that what we might be doing with ever greater medical intervention is prolonging ill health, therefore. And I would go with the logic of what you're saying, which I think is that more sort of upstream public health, population health type interventions, in any case, are more likely to be cost effective. So that's what I think I would point. I think I'm just agreeing with you. And then if you check out the blog, there's a sort of fuller description of that. That question is also at the heart of the report I was pointing to that Chris Whitty did in 2023, which is about healthier aging, which has got some excellent stuff in it. And then please do check out the source of the chart that I shared was the Health Foundation's work doing projections through to 2040. I think Liverpool did it. It's excellent. It's really, really good and terrifying.
Okay, thank you.
So deep breath and then go in.
Thank you, Jonathan. So should we go back to a couple of questions on Slido? I'm sorry for working you so hard, Fraser,
okay.
when you're when you're not very well today. And I should say thank you again for stepping in at rather last minute. We all of us we do very much appreciate that. So I'm thinking you can see the ones that I'm looking at because I'm sharing my screen. So I'm picking out one or two that are relating to the questions that you asked. There's lots of other ones as well, which I will share with you after, actually, Fraser, because I think they are. I think they'll be very useful for us to sort of consider some of the things that people are saying in the work that we are sort of as a strategy unit that we're doing on this as well, just to make sure that we've got. That we've covered some of the issues that people are raising when they're relevant. So this one here says I'm involved with. Is this the one I wanted?
Yeah,
I think it was.
Hang on, don't switch.
Okay.
I've just got my head into that one.
Okay, sorry. Here we go. I'll read it out. And I know people can read, and that might be annoying, but I'm going to do it anyway. So I'm involved with evaluating community interventions. What I'm tackling is people not thinking about evaluation at the start. Therefore, data required is not being collected, but also it's often expected that outcomes are to be obvious, clear, short term, but many actually are around prevention. So outcomes will be longer term, and measuring forecasting impact is difficult. That sounds like a public health colleague. What do you think about that, Fraser?
I just agree. I agree with them, and I wish the world was different. One One thing that you might think is that we've been trying to make this shift from hospital to community, at least on my account, for about 5 decades. I mean, I think unequivocally for about the last 3, say. Well, if that's true, you would expect, wouldn't you, an approach whereby we were trying particular services, particular programs, particular approaches, interventions, whatever it might be, and systematically evaluating them, because we would expect that this problem is durable and that we'll still be engaged in this in 10 or 15 years' time. I mean, I assume everyone on this call thinks that in 10 or 15 years' time, we will still be engaged in this question. If that's true, what are we doing to evaluate more systematically and to gain evidence as we go through? But I wouldn't just point that finger at the evaluation community. I would also point it at the policy and program designers. We don't attend enough to evaluability of programs and policies at the design stage. If we really did think that, you know, we're just stewards of this system for the time that we're engaged in it, we should, you know, accumulating knowledge would be an excellent legacy. We would be designing policies and programs to allow knowledge to accumulate, and I don't think we do. We tend to just roll things out. The risk strat example would be a good one there.
Yeah.
Oh, sorry, tiny sort of fragment of hope in this with a lot of these community interventions. A lot of the outcomes that you might be interested in measuring are, of course, extremely difficult. You know, use of hospital care or health outcomes, or, you know, like a zillion things that are hard, particularly where you're trying to gain traction because you need a counterfactual. There are some areas of measurement, though, or some types of benefit, particularly for staff, where I think you might be able to drop the need for a counterfactual and just ask people. So if I could find people who were saying, you know, do you know what, for example, neighbourhood ways of working, I just think they're better. As someone who's working in the system, as someone who's experienced things previously, I just think this is better. If you had confidence that everything else was broadly the same, or at least not getting worse, that might settle it, actually. So there might be some shortcuts to some of this.
Absolutely. So I'm just going to sorry if it feels like I'm cutting you off. I'll just jump to that one which mentioned the role of analysts, and then I'll probably pick up some of the more recent ones. And people will accuse me of being extremely random in my selection of questions. I'm not. There's a system. I promise there's a system. Here we go. There's a role for analysts to unpick the heterogeneity, I can't say it, of communities or neighbourhoods, so we can understand what models of delivery work in communities. Hospitals all pretty much look the same, so application of evidence-based practice is more straightforward. Communities vary in terms of populations, but also assets. They are very different, aren't they? Up and down the country, from one community to the next. Have you got any thoughts on that, Fraser?
No, just again, just to clap loudly at the intention in that question and the view in that question. I think that's absolutely spot on. In some ways, the further away you get from very well standardized and very well studied clinical practice, and you get into things that look a bit more like community development, in some ways the study problem gets harder, which I think this is pointing to, and you're going to tend towards methods that are a little bit almost look a bit more like anthropology and sort of thicker, richer descriptions of what's going on. Partly I think you would do that because if you look at some predecessor neighbourhood programs, you know, showing his age here, like the New Deal for Communities program, one of the things that comes through in the evaluation work there is that there are sort of quite intangible or difficult to spot in data effects that seem to be doing the causal work, which is about the extent to which residents feel engaged in their neighbourhood or feel like the relationship with services is a bit more one of equals rather than the subject of intervention. You're not going to spot that in data. You will spot that through the kind of work they're describing there. So yeah, spot on.
Absolutely. Well, I think we've got time for a couple more before I let you go, Fraser. There are some which I think are more relevant than others, and I think I'm just going to jump to a couple of the recent ones, and then I'll flick through. So this one here has just been posted. So speaking of counterfactuals, tools such as causal reference are making evaluation of community and preventative care much more feasible. So Jamie Wong's causal inference for intervention and service evaluations handbook will be a useful resource in this regard. thank you very much. That sounds like a very useful resource, and it's there's a nice link here to the which is reference to that on GitHub. So thank you, whoever contributed that. I can share these links afterwards as well for people who are interested in finding out more about that. Someone is agreeing with everything apart from the small growth in primary care activity shown, which doesn't seem to fit with the usual narrative.
Just look, I won't pretend to understand the detail of the data that we use for that. I'm just going to point them at the real report with the
Yeah.
which I just think is excellent. Actually, we that's not because it's our work. The Health Foundation did oodles on it. It's an excellent piece of work, but
Yeah.
also the work that Stephen Wyatt did for the Midlands Decision Support Network on primary care, where he looks at how different approaches to measuring primary care activity have played out. And the way in which I think what we're pointing to there is the usual narrative actually rests quite a lot on some experimental statistics that are perhaps being used for a purpose they weren't designed for. So maybe that explains that gap.
Okay, thank you. We've got a question in the room which we can take. Siva, do you have a question or a comment for Fraser? Are you might be
yeah.
Hiya.
Yeah, I think one of the things in what we do is the problem is analytical views. Couple of things. Modeling is one thing, and second thing is about segmentation, and especially when you try to shift demand from acute to the community. So how do you segment that can represent the demand in the acute sector, apart from the standard segmentation things about age, ethnicity, deprivation, long-term conditions? Those are the standard ways of we segment the data. But is there any recommendation or anything that analysts can do to look at a different way of looking at things, and also modeling at a neighborhood level in terms of outcomes? That makes sense.
Yeah, sure. The question about segmentation, I just think you should ask a proper analyst. I won't stray into that territory. There are much finer minds than mine.
In terms of the concept and idea, that's what I'm trying to get at.
I point you at. I think Rich Wood in Bristol has done oodles of stuff on this, and I think I imagine his stuff is nothing but excellent. The question of modelling, though, because we've been engaged in some of this in the strategy unit. One question you might ask of things like neighbourhood working is what effects might we expect in terms of things like reductions of hospital activity? Of course, those models are going to work upon the assumptions about effectiveness that you plug in, and the assumptions about effectiveness that you plug in, you really want them to be drawing off better evaluations from the past. And for a million reasons that I think, sort of hinted at but not really explored, we've just churned through some quite bad evaluation cycles, and the general evaluation culture in the NHS has just got a long way to go. I think we content ourselves too much with sort of good practice stories and we just don't do enough proper impact evaluation.
Thank you, Siva. Thank you, Fraser. We've got 1 minute to go, so that's perfect timing. So it's perfect timing for me to say thank you very much for sharing that with us, Fraser. I think the groupie has left the room, but I suspect they'll be back. It's the nature of the role, and so I'd just like to finish by thanking you and thanking everybody else for coming, but I just got enough time just to remind people that it was only just over a month ago that we had Hacker, and the recordings are available. They were available a few weeks ago, but people have had Christmas and New Year between then and now, so please do go and have a look at some of that excellent content. That is a picture of Ben, and that wasn't last year because it was online. And just a quick reminder of what's coming up in the next few huddles. The next huddle, we hope, it's going to be confirmed, but we've got a journey to create the domestic abuse strategy and implementation plan for the Isle of Wight Council. I think we're doing some other work with the Isle of Wight as well, aren't we, Fraser? I don't know how that is. I'm sort of, we must be drawn in that direction. So Nicola, who actually was trained in the West Midlands, is coming back to tell us about that. We haven't had domestic abuse talked about yet at a huddle, so I think that'll be a very interesting topic. Then we have quantifying categories of potentially mitigatable activity. What a mouthful that is. Some of that has been referenced by the work that Fraser shared today. And then we're looking at diverting children's urgent care. Again, a new presenter for us. We haven't had Children's Hospital Alliance present for us. So I'm really looking forward to that. It was a massive eye opener to see what they did and the data they had access to. Then we're looking at some of our own modelling for the strategy unit, and that's with Lucy Morgan and Ewan Hahn, and that's looking at the renal pathways, and we've been spending a lot of work on that, and that's going to be around about the time when we launch it on Ireland as well. And there's lots more. So thanks again, thanks again, well, for coming. And I will just stop sharing my screen. And I very much look forward to seeing everybody in